two eminent speakers, Dr. Subha Aniruddin, who's the professor in Ramakrishna Dental College and Hospital, Dr. Ramya Varghese, who is a reader in Ramakrishna Dental College and Hospital, Coimbatore. I request our principal to say a few words. Welcome, sir.
Good morning. At the outset, I would like to congratulate Team Endo for organizing this event out of the box. Thanks to our resource faculty, Dr. Subha and Dr. Ramya. Thank you, ma'am, for sharing your expertise and accepting our invitation. All the delegates here are going to have a good day of experience with these eminent speakers. All the very best for this program, and thank you so much.
This is our schedule for today. From 10 a.m. to 11:15 a.m., Dr. Subha will be talking on biomimetics in restorative dentistry, concepts and techniques. We will have a tea break from 11:15 to 11:30 a.m. From 11:30 a.m. to 12:45 p.m. Dr. Ramya Varghese.
Volume is there.
11:30 a.m. to 12:45 p.m. Dr. Ramya Varghese will be talking on restoring endodontically treated teeth with biomimetic approach strategies, concepts, and techniques, which will be followed by the validatory function. Please take the time to answer the pre-test questions now.
Introduction of speakers only.
Please post your queries on Zoom link and YouTube. Those are on YouTube, you can post your queries on YouTube. Those are following the Zoom link, you can post your queries in the Zoom. I request Dr. Deepa to introduce Dr. Subha Aniruddin. Over to Dr. Deepa.
Happy morning. It's a highly privileged to welcome both the speakers for the today CDE Out of the Box 2023. Dr. Shubha Aniruddhan and Dr. Remya Varghese. Let me introduce the first speaker for the today's session, Dr. Shubha Aniruddhan. Shubha Aniruddhan is a professor in the specialty of conservative dentistry and endodontics at Sri Ramakrishna Dental College and Hospital, Coimbatore. Ma'am completed her undergraduate from Maulana Azad Medical College, Delhi, and postgraduate from Government Dental College, Amritsar, Punjab. Ma'am was awarded with gold medal for the best outgoing students by Delhi University, and she is also the recipient of the best outgoing student award at national level from Pyrie Fawcett Academy. Dr. Shubha ma'am has various publications in national and international journals, includes Journal of Endodontics, Evidence-Based Dentistry, Restorative Dentistry and Endodontics, and Journal of Conservative Dentistry to her credit. Ma'am is a reviewer for journals like IEJ, Journal of Evidence-Based Dental Practice, and Microscopic Research and Techniques. Ma'am is a regular speaker at Tamil Nadu Dr. MGR Medical University Research Methodology Workshop. Ma'am was recently awarded the Masterclass Award by Conservative and Endodontic Association of Tamil Nadu for her achievement and
She's not finished. I request
Dr. Remya Varghese is a reader in the specialty of conservative dentistry and endodontics at Sri Ramakrishna Dental College and Hospital, Coimbatore. Ma'am completed her undergraduate and postgraduate from Tamil Nadu, Dr. MGR Medical University, Tamil Nadu. Ma'am has various national and international publications to her credit, and she presented papers in national and international conferences. Her area of interest are adhesion, biomimetics, vital pulp therapy, microscopic assisted dentistry, and aesthetics. We welcome you, ma'am, for today's session.
now Dr. Subha will take over. We welcome Dr. Subha.
Thank you, Dr. Deepa, for the introduction. At the outset, I'd like to thank Dr. Sharat, Dr. Sabina, and Dr. Karthik from KSR Dental College for giving me this invite. Today's topic is on biomimetics. Is my screen visible?
Yeah,
Is
audio
my screen
very
visible? So today the lectures are going to be in two parts. I'm going to be talking about the concepts and techniques of biomimetics, while Dr. Ramya, my esteemed colleague, is going to share her expertise on the techniques used in biomimetics. We are from here. This is the city where I live in, Coimbatore. And this is the place of my work, which is Sri Ramakrishna Dental College and Hospital. I'm currently working as professor in the Department of Conservative Dentistry and Endodontics. For any technique to be good, to gain expertise in any technique, to perfect anything, you need a lot of experience. You need to work on it for a very long time. It takes years to perfect anything. And the time taken, the leisure of time is with the nature. So nature over so many years has perfected each and every part of our body, so many things in nature. So instead of trying to learn new things, try using our imagination. Even our imagination is fueled by nature around us. We have tried to copy what is in the nature and achieve amazing results. Now, the first thing which we have tried to copy is actually the aesthetics. As you can see from these back statues of famous personalities. But though aesthetics is copied, but it is a little daunting to copy the functioning and the biomechanics of what nature has come across. So using nature as a muse is the best thing we can do to incorporate biomimetics in dentistry. So nature is our model, measure, and mentor when we use biomimetics in dentistry. And we try to preserve the intact tooth structure and restore function and biomechanics of natural teeth. Before I start with my lecture, I would like your opinion on what are your expectations from biomimetic restoration. Those who have a Google Lens, you just click on the Google browser and click on the lens feature of it, and you will be taken to Slido where you can post your opinions. Otherwise, click on slido.com and type the number 1846301 and you'll be taken to that poll. What is your perspective of biomimetic restoration? You can scan this QR code or go to slido.com. Let us have an interactive session. Sabina ma'am, you can ask your postgraduates to type their expectations on biomimetic restorations. So I have my first post, which is perfect fit and aesthetics. Very nice. Natural tooth-like material. Preserved tooth structure, it should, yes, it should mimic natural function, should have a good strength. Yes, material that has characteristics similar to that of the teeth. All right, so far I have received 6 polls, and from your inputs, I can make out that just a second, there seems to be a glitch here. So yes, all of us want the best of aesthetics, natural function, and longevity or long-term survival from our restorations. So the biomimetic principles try to save or preserve as much of tooth structure as possible and rely entirely on adhesive hard tissue bond. And these two together is re-establish the full function of the tooth by transferring function to the tooth, the occlusal stresses to the tooth, and form a single biologic and aesthetic functional unit. And how is it achieved? You maintain as much tooth structure as possible and try to use materials that mimic the natural tooth structure. This is enamel and dentin. And these materials should be able to absorb and distribute stresses like the tooth structure with a durable adhesive bond. So what all features are there, or what are the key concepts that govern biomimetics? The first one is the caries removal strategy and caries removal endpoints, which will enable you to remove only the diseased tooth structure and preserve intact tooth structure. So the preparation design is governed entirely by the tooth rather than the restoration. And you use biomimetic restorative materials which follow to biomechanical principles and adhere to the tooth structure. So we have to use a strategy that maximizes adhesion to the tooth structure, restoring the functional integrity of the tooth. And finally, when these adhesive materials are used, the stress transfer from the material to the tooth should be good, but any polymerization stress should be minimal. So when I was thinking about talking about certain concepts of biomimetic dentistry, I realized that there are a few common questions which everybody will come across. We have certain doubts that what is biomimetics, what is the difference between biomimetics and traditional dentistry, and there is so much to cover in biomimetics. The few common questions which you may be having, I have tried to discuss those in this lecture. The first thing is that I'm doing aesthetic dentistry, and how is biomimetics different from traditional dentistry? So here, even if you're doing an aesthetic restoration, maybe you're giving a zirconia crown, doing an aggressive tooth cutting, it may mimic the tooth in aesthetics, but it is nevertheless not a biomimetic restoration. Not all aesthetic restorations are biomimetic. They have to follow a few principles and strategies laid down by the concept of biomimetics to be called a biomimetic restoration. So here, the preparation design is entirely governed by the amount of tooth structure that is remaining. Therefore, and the entire reliability is on adhesion. Now, when you're removing minimal tooth structure and you're trying to remove caries to a caries removal endpoint, what happens is there is more amount of tooth preservation, resulting in a restoration which will have lesser chances of complication like pain or fracture. And the entire unit will be following with biomechanical principles. For example, in a badly broken down tooth, if you try doing a crown preparation, you will be losing almost 75% of the tooth structure, which may actually require that at a later stage, we have to go for a root canal treatment. Whereas we try to follow biomimetic principle, it may actually preserve the tooth structure and render the tooth as a good functional system. Now, as I said earlier, biomimetics relies mostly on adhesion, and the newer strategies have resulted in a bond strength which is increased up to 400% as compared to the bond strength which we were getting earlier using traditional composite restoration. So for this, what do we need? I want a biomimetic restoration, and I want it to have good aesthetics, I want it to have good adhesion, I want to have a good functional transfer, and I want it to last a lifetime. So for this, I need to choose a good material, and I need to have a good preparation strategy, which will come mainly from my knowledge of the tooth biomechanical principles and stress transfer. And then I can give different types of restorations based upon what is the condition of the tooth. First, coming to the biomimetic materials. These biomimetic materials are synthetic in origin and mimic the biology. They have a good bond with tooth structure and do not elicit a response. So from a material, what do I want? The main two things, apart from aesthetics that I desire from a biomimetic restorative material, is elastic modulus and surface hardness resembling that of the tooth structure. Obviously, we still have not emulated nature to its entirety. We still have some lacunae in the materials. Therefore, research is still going on. But there are a few materials which come close to this requirement. And these materials are glass ionomer cement, dental composite resins, and dental ceramic. Now, coming to glass ionomer cement as a biomimetic material, yes, it has fair enough or decent aesthetics, and it has less shrinkage and less micro leakage, and it also has chemical adhesion, but it fails to meet up the standards of tensile strength and wear resistance of the teeth. Even the newer modifications of glass ionomer cements like yttrium stabilized zirconia containing, they have been able to achieve a good coefficient of thermal expansion and tensile strength close to that of tooth structure. But again, the hardness and elastic modulus are still not at par with that of enamel or dentin. Therefore, when we consider GIC as a restorative material, I would say that you can choose it as an intermediate restorative material in most of the cases rather than as a permanent restorative material. So what is the next material which we come to? As a direct restorative material, or even sometimes as an indirect restorative material of choice, resin-based composites are far better as compared to glass ionomer cement because they have a good surface hardness and wear resistance. But again, their flexural strength and elastic modulus still needs to be comparable to that of the tooth structure. Therefore, a lot of modifications, the new modifications were made, and we have got nanocomposites, modifications in the fibers, in the matrix, resulting in composites which have a high strength, high stiffness, good shear and low density. So earlier we were using microfills and micro nano hybrids. We have come now to the stage of having multi-functionalized fill composites, which are stronger, have lesser polymerization shrinkage, exhibit good mechanical, optical, and thermal properties through nanoparticle reinforcement. One such material is smart dentin replacement. Now, this has a good filler, nanofillers, and it also is like a self, it is flowable in consistency, so it is able to adapt very well to the tooth structure, and it also sort of levels itself. Instead of us requiring to contour it, there are different materials, packable composites, bulk fill composites, which are available. And these materials have markedly improved the quality of the restorations which we are achieving through biomimetics. So at this juncture, I would like to say that from this section, we have two take-home points. One is that biomimetic dentistry has the tooth preparation governed by tooth biomechanical principles, and we have been able to achieve good restorations mimicking the tooth biology through improvements in composite chemistry and composition. The next question before I come to that, I would like to state that the entire crux is on the adhesion. So we need to restore the tooth in such a manner that the adhesion is intact. So for that, you need a good caries-free peripheral seal, and you use different techniques like immediate dentin sealing, gold standard bonding systems, deep margin elevation, which I'll be explaining to you in just a moment. Now, caries removal traditionally has been used. We do use indirect and direct pulp capping, but what is the difference in caries removal strategies in biomimetic dentistry? That is caries removal endpoints. That is when to stop removing caries and create a peripheral seal zone. So when you're using your caries removal, it is always advisable to use a caries removal using a caries detecting dye. Once you place the dye and then you leave it for about 2 to 3 minutes and then rinse it off, you will end up in something looking like this, where you have the dark areas which are soft caries which need to be removed, and you have to start excavating using initially your spoon excavator and later a round burr rotating at slow speed. And once you remove it, you will end up in in something which looks like this. There is an outer zone of enamel followed by DEJ. Now DEJ is hypocalcified. So when you are removing caries, you may confuse the dentino-enamel junction with active caries. A word of caution there, DEJ always stays dark. So do not remove the DEJ thinking that it is soft caries. Inside that, you will be able to see a light pink stained dentin, which is after the caries has been removed, and a slightly darker pink dentin, which is actually deep dentin, which is superimposing on the pulp. So this is what it looks like. This is the peripheral seal zone, which is this zone surrounding the deep dentin. It's free of outer and inner caries dentin, and it is lightly stained. Now, what is the caries removal endpoint that I was talking about? So you continue to remove caries. It may not actually be an ideal case to do restoration, because when you see it, what happens is sometimes there may be a pulpal exposure due to caries. So keep these two. The rule of thumb is that going 3 millimeters within the marginal ridge and 5 millimeters from the occlusal surface. If you are going beyond and trying to remove caries, you may most likely result in a caries exposure. because of which stop there and think of doing an alternative treatment like indirect pulp capping or a root canal treatment if the patient is symptomatic, rather than going for a peripheral seal zone with immediate dentin seal. Now, we come to the crux of the matter, which is how to improve the bond strength in biomimetic dentistry. So as I said earlier, adhesion is a very important concept in biomimetic dentistry. And the latest research has been able to achieve bond strength in dentin, which is very much comparable to that of enamel. And one of the concepts involved in this is immediate dentin healing. So what the concept behind immediate dentin sealing is that when you do immediate dentin sealing and later on you either bond an indirect restoration or give a direct restoration, the bond strength would have improved to 400% increase. How is that possible? First thing is the bonding substrate should be free of any tail. And you allow the dentin some amount of time to develop. The bond should be given some amount of time to develop before you bond another restoration or you give a direct restoration. So the concept is that freshly cut dentin is very conducive to bonding. So whether you're giving a direct restoration or an indirect restoration, immediately after cutting the dentin, you should give your bonding agent. And you apply a primer, you apply a bonding agent, and then mask out the undercuts, and then later adjust the preparation design and make an impression. Now this, once the preparation is adjusted, after that you make an impression, give a temporary and send the patient home. So what does it mean? Am I supposed to cement the indirect restoration in the next appointment? Yes, that is what I'm talking about. When I'm giving an indirect restoration, immediately after preparation of the tooth, I have to do a bonding. I have to follow the bonding protocol, make the impression and send the patient home. Next, in the next appointment, when the patient comes back, I can do a light air abrasion, and apart from that, I can do enamel etching and bonding before cementing the restoration. This will achieve a very good bond strength. Now, what about direct restorations? I'll come to that in just a moment. What is the advantage of immediate dentin sealing? It prevents dentin contamination. How? The freshly cut dentin is exposed and you give a temporary and send the patient home. Obviously, through micro leakage, all the dentinal tubules are going to be contaminated with bacteria. And then the hybrid layer will be subpar, which is formed after I go for an indirect restoration. It avoids gap formation and improves bond strength and minimizes the residual strength. Now, what about direct restorations? In direct restoration also, we can use the concept of immediate dentin sealing. So what do I do here? First thing is that I prepare my cavity and I then place my bonding agent. Now, I wait. I wait for 5 minutes because this bond needs time to mature. So when I wait for 5 minutes and let the bond mature, and then after that, I apply my composite restoration, I achieve a very good strength. There are golds, but remember that there are gold standard bonding systems such as Clearfill SE, Aqua Single Bond, OptiBond Solo, and iBond Self Etch, which we should be using when we are trying to use. Obviously, the quality of the bonding agent is very important, which governs the bond strength. So you can see here one case where the restoration has been placed. Cavity has been prepared using dye. After removal of the entire caries, there is immediate dentin sealing, which has been done. A very good article by Van der Bremer et al. Showed that the when you use immediate dentin sealing, in cases clinical evaluation. It was an in vivo study. They showed that when you use immediate dentin sealing, it achieved very good bond sting. The post-operative follow-up showed that where there was very little loss of restorations, which were restored after using immediate dentin sealing with photopolymerized composite resin. So at this juncture, again, I would like to stress on a take-home point, which is immediate dentin sealing improves bond strength in both direct and indirect restoration. So today itself, you can, when you're doing your composite restoration, you can practice immediate dentin sealing. And when you're planning a ceramic restoration, think about immediate dentin sealing and start doing that, start practicing that also. Again, there have been so many doubts about a technique which will reduce polymerization shrinkage stress. When I talk about polymerization shrinkage stress, the immediate answer which comes to all our minds is using a layering technique. Is that enough, or are there any other new techniques which are available to reduce polymerization shrinkage stress? This is known as the stress reduced direct composite technique. So, as I said, you have immediate dentin sealing, which will allow for maximum monomer conversion, resulting in a very good bond strength. Apart from that, in deep cavities, we can use certain other methods to reinforce the bond. So reinforcing the bond is done with the help of a flowable composite. A thin layer of flowable composite about 1 millimeter in thickness will help in reinforcing the immediate dentin sealing layer. And then again, the restoration follows the small incremental buildup of composite and using a good light cure along with soft start cure. So here is a small video which shows how we are building a reinforced IDS layer. This is the primer, which is dry. And after that, we apply a layer. Actually, we apply 2 layers of self-etching bonding agent. Now you can see there is pooling of the bonding agents in certain areas of depression. So the excess is taken out with the help of a micro brush, and then this is cured. Now those areas which are very deep and which require reinforcement only on the dentin, as you can see, the enamel has still not been restored. The flowable composite is placed, and we're checking what is the depth with the help of a graduated probe, and then cure it. Now, after this, any undercuts which need to be taken care of can be removed. You place a more viscous composite and then cure it. And now this tooth is ready for making an impression. The next question is, when I'm using a direct composite restoration, what is the incremental technique that we should use? So the first increment is very important because this is what will determine what is the amount of polymerization shrinkage stress which the tooth restoration interface will face. Okay, and on the cavity floor, when you try using a vertical or oblique layering technique, studies have shown that the adhesion is very poor. So when you're thinking of bonding the cavity floor, you should use the horizontal layering. But if you have a class 2 restoration, the first buildup should be on the proximal wall. So you do a proximal wall buildup, then start with a horizontal layer, and then you can use oblique increments which will bond only to 2 surfaces rather than 3 or 4 surfaces. So the number of surfaces which are available for which are bonded and which need stress relief are reduced. So the C factor is also reduced. And this is what we should do. Another method of reinforcing the bond and improving the stress bearing capacity of the restoration is to use fiber inserts. Now, fiber inserts are becoming very popular. What you do is you do an immediate dentin sealing, and after that, you give a fiber insert incorporated with your flowable composite. So you give a small coating of the flowable composite and then place your fiber insert, adapt it well so that it soaks the flowable composite and then cure it. So this results in something called a bio base. What does it do? It increases the composite toughness, and because it is like a net spread over a wide area, it mimics the crack shielding mechanism. So it's something like this. So if you have a restoration, there is interlayer stress distribution without the membrane, but you can see here when with the membrane or with the fiber insert, what happens is there is a wider area over which there is a buffering of the stress. Just like when someone falls from a height and falls on a net, there is a cushion effect. The same way, there is a cushioning effect which is given by your fiber reinforced composite. So again, the take-home point will be that flowable composites will reinforce the immediate dentin seal and are very good at protecting the hybrid layer. And the reinforcing fibers which are used will help in distributing the occlusal load and also control the amount of polymerization shrinkage. The next commonly encountered problem with deep cavities is having subgingival margins. So whenever you have subgingival margins, restoring it either with a direct restoration or an indirect restoration is very difficult, because what happens is that if you are planning to give a indirect restoration, the margin is not recorded properly in your impression, and the resulting restoration will be at having inadequate adhesion, resulting in a gap formation at the gingival margin. If it is a very big restoration, the light has to travel through the entire ceramic to reach the gingival area, resulting in an incomplete cure of the bond. And obviously, there is a problem of shrinkage stress also. So to avoid this, there is a concept of deep margin elevation. Now, the term may be new, but the concept is not. Earlier, we used to call it as open sandwich technique or elevating the gingival seat, coronal repositioning of the margin. These are all terms which are synonymous with deep margin elevation. So what you're doing is you're actually taking the margin using a material and elevating it higher than the gingival level. So in deep margin elevation, we again use a flowable composite to raise the restorative margin to a supragingival location. Because of this, what happens? You can see here, in perfect isolation, what we have tried to do is, we have tried to elevate the gingival margin. Now, once this is done, the recording of the impressions, whether you use an impression material or you try using a digital impression technique, the impression margins will be recorded very well. And the height of the restoration, the height of your indirect restoration will also be reduced. So the amount of light which will travel to the gingival region will also increase. And in the cervical region, tooth has a tendency to flex, whereas ceramic restorations are very rigid. So composite restorations flex along with the tooth better than ceramic restoration. So because of this increased flexion along with that of the tooth, the chances of gap formation for these restorations are better as compared to your ceramic restoration. So you can see here another case where there was a subgingival margin under rubber dam isolation, first immediate dentin sealing was done. And then after that, the deep margin was elevated to a supragingival level using a flowable composite. Now, a word of caution here, just because the margin is subgingival does not mean that all the margins can be elevated to the supragingival level. Now, in this case, there was a complication that even after adaptation of the matrix band, there was a gap, because of which there was a gap between the matrix band and the gingival margin. So in this case, what we have used is a Teflon tape. So a Teflon tape was inserted to ensure adaptation of this matrix band to the gingival seat before a flowable composite was placed. Here is another case. Now there was an oblique fracture, and the oblique fracture went subgingivally. Now, in this case, immediate the margin elevation, deep margin elevation could not be done just like this, because the margin, even after rubber dam isolation, it could not be isolated perfectly, which meant that there was some amount of gingival recontouring and some osseous recontouring could be required. So with the help of the Department of Periodontics, what we did was we did gingivectomy along with osseous recontouring, and then only we were able to isolate the tooth and elevate the gingival margin. You can see in the radiograph here, this is the oblique fracture after obturation. And after this, after the surgery, this is where our margin was. We did a deep margin elevation along with that. And then after 1 year also, the bone height is maintained. So again, the take home point is that you can do a deep margin elevation to achieve predictable long-term survival rates and restoration. And deep margin elevation facilitates impression taking and adhesive cementation of indirect restorations with subgingival margins. We come to the next material, that is dental ceramic, which have good strength, good hardness. But then when you want to do a ceramic restoration, the first thing that comes to our mind is a crown preparation. And many people associate ceramic crowns with aggressive tooth reduction. But in biomimetics, we don't do that. We try to preserve tooth structure. So what are the strategies which we use to preserve the tooth structure when we are trying the biomimetic approach? The technique of tooth preparation and what all kind of tooth preparation can be done will be explained more in detail by Dr. Ramya, who is an expert in this matter. I'm going to throw my light on the superficially on what morphologically driven preparation techniques are about. So these follow the geometry and structure pattern of the tooth. And when we follow what is the concept behind why the tooth is designed as such, why nature designed the tooth in such a shape, we come across so many answers and so many wonders that such a small structure has so much science behind it. And now with so much research going on, we have been able to find out some answers, and because of these answers, our knowledge base has improved, and we have been able to design different preparation techniques which avoid loss of healthy tooth tissue and maximize hard tissue conservation. So because of which you are able to plan indirect adhesive restorations using structural and geometric criteria of the tooth structure. So some of these newly developed restorations are occlusal veneers or tabletops, and an offshoot of a veneer and an occlusal veneer is a overlay or a veneer lay. And then you have, for more extensively destroyed teeth, you have long wrap overlays. So just to touch upon what these are, occlusal veneers are also known as tabletops, and they have partial coverage restorations. They are not full coverage restoration, but they are covering only one part of the tooth, and that is the occlusal surface. And they are most commonly indicated where teeth have tooth structure loss because of erosion, and when you're planning to increase the vertical dimension because of gross attrition all across the oral cavity. And sometimes they may also be indicated when there are certain occlusal tooth defects, which have resulted in either bruxism or myofascial problems in the patient. So this is one case where the tooth preparation has been done and has been successively restored with a tabletop. You have a veneer lay preparation. A veneer lay preparations are very good indications where there is a buccal surface or a palatal surface loss only when the other surface is intact. Now, this is a case where the patient had a shear fracture. She had an injury to the left jaw, which resulted in the shearing of the buccal cusp as well as some amount of the buccal surface, buccal tooth surface. This is the occlusal view. And what was planned was just a restoration of the buccal surface and the occlusal surface. She had come back after fracture of a composite restoration which was given, and she wanted a conservative treatment. So after the preparation, this is what it looked like. This is the preparation, which covered only the occlusal surface, following the cusping lines and the region till the tooth structure loss was there. And we were successfully able to cement. And after 1 year follow-up also, the patient was very happy with the restoration and its aesthetics. There are other ways now, instead of going for a veneer lay, if you have a mesial distal tooth structure loss, you can go for something called a long wrap overlay. Now, why are we trying to preserve the tooth structure here? First thing is because we are able to. We are able to achieve good adhesion even without trying to get good taper, ferrule effect and everything. We are able to use adhesion and we are able to achieve a long lasting restoration. But one more reason is that the tooth above the height of contour and below the height of contour is acting as an entire unit, which we call the compression dome. So the structure above the height of contour acts as a dome which keeps the dentin under compression. So if you remove tooth structure beyond the height of contour, the effect of this compression is lost. Okay. So this compression dome is known as the biodome, and the tooth structure or the enamel which is surrounding circumferentially beneath the height of the contour is known as the biorim. Many a times you need to remove the biodome, that is the occlusal enamel, but what you should do is you should try to preserve as much as possible and try to make sure that the biorim remains intact. So what happens is the dentin remains in compression rather than being in tension. And we know any tooth structure which is under tension has a tendency to fail more as compared to when it is under compression. So this is another image of the dome and the biorim, and this is the circumferential enamel beneath the height of contour. In this case, what we have done is we have done the preparation. All the surfaces are involved, but what we have done is we have tried to keep the margin above the height of the contour. So when the margin is above the height of the contour, the margin design which was given was a concave hollow ground bevel. If it goes below the height of the contour, usually a shoulder or a rounded shoulder is advised. So the take home point after this is that morphologically driven tooth preparation follow bioemulation principles during tooth preparation, and they minimize dentin exposure and maximizes hard tissue preservation. So when we are using biomimetic approach, we should think about what is the structure of the tooth, what is the position of the tooth in the arch, how it goes about, how we can go about preserving maximum hard tissue without compromising on the tooth structure. And then when we are planning the restoration, we have to follow all the biomimetic strategies to help restore form, function, and aesthetics of teeth with minimal compromise to tooth structure. And then the materials which are available, we have a wide variety of materials available. For direct restorations, we should go for composites which are reinforced with nanomaterials. And we can, now the material of choice for ceramic restoration is predominantly lithium disilicate. Dr. Ramya will be throwing more light on this in just a while. We can use, please use immediate dentin sealing because it has been shown, it has been proven that it improves the bond strength. So your restoration will never fail because the adhesion was poor. It will stay intact and the patient will not come back with the restoration in their hand. So please follow proper protocols with preparing your restoration. And remember, even all these techniques and concepts can be utilized today. Don't say that I don't have the latest advancements which are available. Use your knowledge, use your talent, because even if you have resources, if you don't know how to use them, it will never be enough. If you have any doubts or you would like to contact me, I'm reachable through my email, which is subhanirudhan1@gmail.com. There are so many people I'd like to thank. First of all, the Department of Conservative Dentistry from KSR Institute of Dental Sciences and Research, Dr. Sabina, Dr. Karthik, and my friend and mentor, Dr. Meenu Koshi, who has always supported me, my students, Dr. Sharon and Dr. Nandini, who patiently sat through the presentation to appraise and give their critical appraisal when I was preparing for this presentation. Thank you so much. If you want to pursue any further reading, you can scan this QR code using your Google Lens. There is a Google document where all the links to the references which I have used for my presentation have been posted. So when you scan the QR code, you can go to the links and download them and improve your knowledge on biomimetics. This is the Department of Conservative Dentistry.
Wonderful talk,
Thank you so much.
Subha. Thank you.
Thank you, ma'am.
Now, Dr. Shankar will ask questions.
That was a very comprehensive lecture, ma'am. Our PGs ask you questions like, what's your take on class 5 restoration and whether if a class 5 restoration gets deeper, if it goes for root canal treatment, how it will be post-endodontically restored?
Now here, yes, that's a very good question because the tooth structural loss there is in the cervical region. So, and that is where you have a lot of tensile stresses and the tooth flexes. So, restoration, obviously you have, when you're doing a post-endodontic restoration of the class 5 at first, you have to apply a flowable composite, which will act as a stress breaker and then do a composite restoration. It is not necessary that all the teeth which have cervical caries or cervical defects without any compromise on the coronal structure should be restored with a crown. You don't need to do that.
Thank you so much, ma'am. We'll have a certificate of appreciation for your. They are getting ready.
Hi, Subha. Bhupati.
Hello, Bhupati, how are you?
நல்லா இருக்கேன். நீங்க எப்படி இருக்கீங்க?
Fine, fine. நல்லா இருக்கேன் நான்.
ஆஸ் யூஷுவல் பிரசன்டேஷன் சூப்பரா இருந்துச்சு.
Thank you so much.
அதாவது தியரி பார்ட்டை ரொம்ப ஸ்கிப் பண்ணிடுறோம் இப்பெல்லாம். ஸோ டெர்மினாலஜிஸ் நிறைய இம்ப்ரூவ் ஆயிருக்கு. ஸோ நிறைய விஷயம் தெரிய மாட்டேங்குதுல இப்ப இருக்கிற. ஸோ அது ரொம்ப ஒரு ரெஃப்ரெஷ் பண்ண மாதிரி இருந்துச்சு. நம்ம பிஜி படிச்சதும் இப்ப அட்வான்சஸ் எல்லாம் கொஞ்சம் ரெஃப்ரெஷ் பண்ண மாதிரி இருந்துச்சு. தேங்க்ஸ் ஃபார் சூசிங் திஸ் டாபிக்.
Thank you so much. Thank you. That was very sweet of you.
Now Dr. Ramya will take, oh, sorry, we will have a tea break for 15 minutes. We will have a tea break for 15 minutes.
Hello, ma'am. Hello.
Yes, Dr. Ramya.
Yeah, is it audible?
Yeah, it's audible, it's audible.
Yeah, I just share my screen and see.
Yeah.
Yeah.
Yeah, we can see the screen.
Now, isn't it? No.
Yeah.
Okay. Okay, ma'am. Thank you. Yeah.
So now I request Dr. Ramya to take over.
Hello.
Yes, Ramya?
1 minute. Yeah. Hi, ma'am. Good morning.
Good morning, good morning.
Yeah, and I think all of you have come back with a sip of tea and energized for the next session. So,
Yes.
yeah. So, thank you very much for the invite, Dr. Sabina and the Endo team. So I think all of you have done with the concepts of biomimetics, all well versed. Now I just want to just go through that. All of you have already know the concepts, what all things we have to follow in biomimetic theory. So today my topic of discussion is restoring endodontically treated teeth with biomimetic approach, strategies, concepts, and techniques. So every time the fracture resistance of endodontically treated tooth or strengthening of endodontically treated teeth is a topic of discussion in our specialty from time immemorial. So out of curiosity, I just searched in Google. The search word was fracture resistance of endodontically treated teeth. And to my surprise, I just saw around 4 lakh plus results for the same with different parameters. Even more, very recently, one more article has been published on the fracture resistance of endodontically treated teeth with another parameter. So we are going to discuss about the strengthening of endodontically treated teeth with new advancements in addition, bonding strategies and biomimetic restorative materials, as well as the new techniques in biomimetics to pop up or to strengthen the endodontically treated teeth. So historically, it was taught to put full crown or a full coverage tooth restoration or full coverage tooth preparation and go for a crown. Whatever be the volume of tooth loss left behind or whatever a small the access cavity, the standard protocol was to, after access or after endodontic therapy, go for a crown. Here, actually, this starts with the violation of the first concept in biomimetics, that is our biorim. We are weakening the tooth and we are going for a fracture later on. So according to Thompson et al., the biorim is very important to preserve the integrity of a tooth or endodontically treated tooth. So why this microdentistry or the biomimetic dentistry or bioemulation dentistry or microscopic dentistry is so much important these times? It's nothing. Actually, we respect the natural structure and use that nature as your guide in restoration. So moving to the details of this presentation, we have to go and to our old second year oral histology class organs. Like we'll start to know, we should know what are the different structures we should give more importance while going for a biomimetics. Let's start all with the enamel. When you talk about enamel, the first thing comes to our mind is the enamel road or enamel direction of the enamel roads. As a conservative and endodontist, the direction of the enamel roads matters a lot for us. And we know it is actually divided into 3, that is the occlusal third, middle third and the cervical third. And we also know occlusal third has got the highest density of enamel roots, and it is almost parallel to the long axis of the tooth. And as it goes towards the middle third, the angulation, there is an inclination towards the apical third and or cervical third, and the density also will decrease. So here, Brazos et al. In 2011 beautifully narrated the histoanatomic approach, how biomimetically emulating the nature of each tooth. In this article, you can see all the maxillary molars and maxillary premolars, and he beautifully narrated how the enamel looks, how the dentin, how the enamel dentin complex for each teeth. So here in this picture is actually a mandibular premolar picture. Here you can see the convexity of enamel, how convex and how dense the enamel. More than that, you just look at the sigmoid nature of dentin underneath that enamel. So we all know this is the most, or enamel is the hardest structure in the human body, but as well as it is the brittle one too. But because of this sigmoid curve or sigmoid nature of this our dentin below the enamel, it gives actually the support for the enamel to preserve its strength. And one more thing you have to look into here in this picture is, especially for the mandibular molars and premolars. Here, both the buccal, the shape of the dentin on both on the buccal and the lingual side is a bit different. Here, you can see that deep S or the sigmoid notch here. But when to the lingual side, you can see it's almost rectilinear. The sigmoid nature is different. It's not there on the lingual side of the mandibular molars and premolars. This, just keep in your mind, when I'm talking about the preparation finish lines, this part will again come across. So next picture is all about the maxillary teeth. In maxillary teeth, both the buccal as well as the lingual side is anatomically, we can see the sigmoid nature is almost as maintaining throughout for the buccal and the lingual side. Again, according to this, the outline of the finish line will change. So what are things you have to keep in your mind before you select a tooth for a biomimetic restoration, or case selection is very much important in case of a biomimetic restoration. First one is the height of condor, as ma'am have already told you regarding the height of condor, the occlusal dome concept, etc. Next thing is the direction of enamel roots with respect to the axial and the proximal surfaces. Then the sigmoid nature of the enamel and dentin interface. Finally, the cuspal incline. This matters a lot for the integrity of the tooth. And without addition or without the bonding strategies, there is no biomimetics. So we should, Veneziani et al. Have generally classified or generally told this adhesive indirect restoration as adesthetics. So this is the other terminology nowadays they are using, like adesthetics restoration. It's nothing, we all know. It's all our posterior indirect adhesive restoration, like onlay or overlay, tabletops, endocrowns, and finally we are reached up to the vertical preparation of the anteriors with minimal reduction in the enamel. So for the completion of this discussion, I want to just go through the in definitions part of all these things. So Veneziani et al. In 2017 beautifully described, beautifully defined this adesthetics, like is the partial crown relation, a restoration made in composite or full ceramic, which has to be seated passively and adhesively cemented into a cavity characterized by specific attributes. And these all definitions are, you are all well thorough than me, I know. So these are all the definitions which you know already, so I don't have to go through it. Inlays and intracoronal tooth colored restoration, mainly to restore the occlusal and the proximal surfaces without involving the cusps, and rarely the proximal surfaces of the anterior teeth. It's a picture nicely depicting the definition well. So this is an inlay preparation. It can either be an MO or an MOD inlay cavity. Again, only when it's a combination of intracoronal as well as extracoronal tooth colored restoration, when one or more cusps are covered. Overlay, which actually cap all the cusps, and veneer lay, as ma'am narrated, our one clinical picture too for this. It's an overlay with involvement of the buccal wall and preparation combined with laminate at the laminate veneer. This is the definition given by Murphy et al. In 2009. This is a picture of onlay, then tabletop, then comes our veneer lay. So tabletop is actually a type of overlay used to restore or rehabilitate an abraded or eroded teeth. Usually we'll go with a full crown, this kind of eroded or abraded tooth. So with the adhesion strategies and bonding and biomimetics preparation, now we have another option rather than going for a full crown for an abraded or eroded teeth. So this is a clinical picture of an eroded teeth and tabletop on after the preparation. So endocrown again, one of the aesthetics nowadays we are using very often, like in case of a short crown where the retention is compromised. If you go for a full crown restoration, in this case we are getting the the retention from the chamber, and we are maintaining the enamel and the integrity as much as possible with this. So indication, it's the ages, all the indications we are just following still now. First indication is the aesthetics. Next one, very large defects, very large caries rest or decayed, which cannot be built up with the normal direct restorative methods. And when there is one or more cusp has been involved, where the proximal contact is difficult to maintain. Next thing again, if there is a cervical cusp fracture, better we go for a biomimetic restoration. And again, for short crown, it's a good indication. Next one, the multiple medium to large sized cavities in the same quadrant. We can go with the biomimetic restoration. Another one, as the other indication, is raising of your occlusal vertical dimension with the help of tabletop kind of biomimetic restorations. So contraindication, actually more than indication, before you choose a case, you should see, is there any contraindication for the same? So the main contraindication is the occlusal, any parafunctional habits or occlusal disharmony like bruxism or end-on relationship. All these things you should look for before you choose a tooth for the same procedure. And another one. Hello. Another one. Am I audible?
Yes, audible.
Yeah. Next one, next main contraindication where the isolation is a problem, then you can try with the DME, but still if the isolation is problematic, then adhesion would be always compromised. So in that case, you have to choose carefully whether you can raise the margin with the DME, then proceed with the restoration. And one more contraindication, which I would like to put, because I have seen two cases here, when there is no quality enamel is present, that is all enamel is no enamel, only tendon is left behind. Like if it is a crown prepared tooth, then it is very difficult to get the adhesion with when no enamel is present. So main contraindication is if there is no quality enamel present, better go with some other procedures rather than this biomimetic restoration. So these are all the general, according to Deliperi and Aleman et al. These are all the few criteria for case selection rather than the indication which we have already mentioned. You should see the functional and non-functional remaining cusp width. You have to see the isthmus width, and you have to see the depth of the proximal boxes, volume of tooth loss, and loss of marginal ridges before you choose the case for your biomimetic restoration. So just brush up on now. We have already planned a case for biomimetic. Next thing, you should know the concepts. So concepts, Dr. Shubha, my ma'am already beautifully described it to you, the different concepts. For a vital tooth, for non-vital tooth, I will explain a bit, like peripheral seals on and caries removal endpoints is for non-vital tooth, ma'am said you have to preserve as much as of tooth structure possibly. Here again, I can tell you the caries removal endpoints here. Actually, we have to limit our access cavity preparation within these parameters to preserve the integrity of your teeth. well. So this not only for the vital tooth, for non-vital teeth or access cavity, also the peripheral seals on, as well as the caries removal and points is very much important. Next concept is the natural biomechanics of the teeth. Like you have to carefully select the material and techniques that closely resemble to the hard tissues such as enamel and dentine. Then the most important one, the biorim, the enamel, which is above the height of condor, and the biobase, even after all your cavity preparation, reconstruct the dentine, which is been lost using by your means of caries or your tooth preparation, and stabilize that dentine and get a more strength or like more bond with the biobase. So preserving the concept is always very important. You have to follow all these concepts in cavity preparation also, or tooth preparation. So next thing, you might have thought, what is the main difference between the traditional cavity and the biomimetic cavity preparation? Nothing. We are doing the same inlay onlay or overlay procedures for ages together. What the next, what is big deal in biomimetic cavity or biomimetic tooth preparation? So when Venesiani et al. Have narrated in this article, which has been published in 2017, like traditional cavity designs, the main problem, we are actually getting the retention with the shoulder, slot, pins, all these are actually less conservative. And rather than that, we are exposing a lot of tooth structure or dentine we are cutting away the enamel and we are exposing the dentine. So it will be always a difficulty you can experience with the dentine and adhesion.
Dr. Ramya, it's not audible.
That hello?
Now I can hear.
Yeah, so you missed a bit. Okay, ma'am, I'll come. So this picture is actually showing the old traditional cavity preparations like what we were doing before. So here I'm just want to put something into your mind or into your notice. Like first one, see the width of the shoulder here. We are actually, the width of the finish line is too much, more than 2 mm all over, and you can see a sharp line angles all here. Next thing I want to put is the location of your finish line. Here in the old preparation technique, the location of the finish line is actually at the cervical margins. That means we have not preserved the biorim. There is nothing, only the cervical margin. As I already told, the density of the enamel rods is very minimal. Another one you have to keep into your mind is this one. Actually, once before and all, when we make a preparation, we just check the uniformity of your finish line. Like it should be uniform, like from the box, from the proximal area towards the buccal or the lingual side. We just take our explorer and run and see whether it is uniform throughout. But these three things are actually different with our biomimetic concept and biomimetic tooth preparation. So Venesiani et al. Actually beautifully narrated a new technique called morphology-driven preparation technique, or MDPT. As the name suggests, all things matters. Here in this preparation, he just morphology is the one which is driving the tooth preparation. There is nothing else. Just go along the morphology of the tooth and preserve the integrity. And this is the picture. These are the different cavity tooth preparation he had narrated with a lot of morphology-driven technique. Here, this is an emphasized or more magnified view of tooth preparation I want to show you. Here again, last slide, I told three things you have to keep in your mind. Now we are going to compare those three. First one, the shoulder width or the finish marginal width or the finish line width. See this here. In the buccal as well as in the lingual side, the finish line is almost 1 to 1.5 mm. There is no wide finish lines. What will happen if there is a wide finish lines or wide margins? We are using always some luting cement like a composite. When you are using a luting composite, chances are there more amount of curing, more amount of polymerization shrinkage can happen. So with this kind of 1 to 1.5 mm, one maximum 1 to 1.5 mm of finish line, we can reduce the polymerization shrinkage. And again, next one here. Next thing, you can see all the boxes are not very sharp. These are all actually rounded line angles you can see. Another one I want to show is the level of your margin. See, at the buccal margin and at the proximal margin, either it's not at the same level. As there is a ramp here, or the staged up preparation, or stage up preparation, or stage up platform here. As we come from the proximal side towards the buccal area, your finish line is actually climbing up. So in this way, we are preserving a lot of tooth structure, a lot of enamel. So next one again, one more thing. I already told you the finish line, what finish line we have to give. So here, I told the sigmoid nature is more evident for the in the buccal as well as in the lingual side for the maxillary molars and premolars. So we can go with the chamfer finish line for both the buccal and the lingual side for the maxillary molars and premolars. For a mandibular premolar, mandibular buccal, we have the sigmoid dentine. So there you can give a chamfer. But on the lingual side, even shoulder preparation will be better because it's just a rectilinear dentine configuration at the lingual side. So you must be thinking what are all the armamentarium which we can use. You can go with any kind of inlay cutting burrs. More than that, I prefer to go with the ultrasonic prosthodontic tips, which is available from acetone. So when you use some ultrasonic prosthodontic tips, these two pictures you can verify. With rotary, there will be always irregularities at the margin, but with an ultrasonic tip, you will get a finish line, which will be always smooth all around. So the recording with the impression will be always easy. And for chamfer again, you can use it, can prepare a deep chamfer by using TR62C. It's a tapering round for the chamfer preparation. And then when you think about the prosthetic ultrasonic tips, it's not only one single shape. It will come both in a chamfered and the shoulder shape. So you whatever finish line you are giving, you can use the same ultrasonic tips for both the buccal and the lingual, either shoulder or chamfer prosthetic tips you can use for preparing and making it more defined. So this is another picture how they are using it. Next one is the MDPT technique. What is it actually meant for? Here we are, see these two pictures. Usually when we are cutting or when we are going for a biomimetic tooth preparation earlier times, we were just cut through the enamel and we are just cut through the enamel and there is no prisms left behind or roads left behind for the more of addition. But with the new technology or with the new technique, here we have to follow a hollow chamfer preparation. When you are following a hollow chamfer preparation here, we are not only just cutting away the enamel, whatever is present at the occlusal margin or the occlusal third, we are exposing more amount of enamel here. So more amount of enamel, more surface area and more enamel roads, more of adhesion, more bonding. So always, rather than going for a shoulder or a parallel to the long axis of that kind of cut, go always with the hollow chamfer preparation and preserve or expose more of your enamel roads and get more addition for the same. And this is a picture or a diagrammatic picture to describe you how the butt joint finish as well as the hollow ground finish differs. So here in the butt joint finish, you can see we are just cutting it out. There is no enamel here to go to for the etching or the surface area. But here, when we are going for a hollow ground chamfer, here we are exposing more enamel and we are preserving this much and exposing more enamel So we will get more amount of addition and more bonding. So Brasler come up with a round microfine diamond bar to develop this hollow chamfer preparation recently for the same. So this is actually MDPT tooth preparation. I just want to tell you more, but with that clinical picture, you might not be having a clear picture in your mind. So the first difference, we'll start with the occlusal reduction. Here, the occlusal reduction, usually what we will do, we'll go, if it is an MO or a MOD or a ceramic onlay or overlay, we just start with our conventional cavity preparation. We'll go with the conventional cavity preparation on the occlusal side. That is actually missing here. We are just going with the butt joint preparation from the occlusal side, and it's just not a straight line, but we are actually following the cusps and fossa of the occlusal plane, and it's an inclined plane towards the occlusal side. So there is first difference. And next difference, always the butt joint is preferable for the interproximal boxes. Mesially and distally, we can give a butt joint of 1.2 to 1.5 mm. And the next thing is the inclined plane. This is the inclined plane. This is very important. This you can create with a chamfer finish line or a chamfer bar. So this inclined plane is the main difference between our normal preparation and the biomimetic tooth preparation. And you can use a truncated cone-shaped bar for the butt joint for the inclined plane preparation, and for the butt joint preparation, and you can use a chamfer finishing bar for the inclined plane preparation. Again, occlusal reduction, one question would be in your mind, how to reduce it. You can either use the truncated cone burr, or even I am using the flame shaped burr for the depth orientation cut. Just use the flame shaped burr, do some 1.5 mm to 2 mm reduction, and just go through the fossas and the sulcuses. So you are getting a smooth butt at the occlusal surface with proper reduction of 1.5 to 2 mm. And we need a 6 to 10 degrees of divergence for the same, for the easy insertion of the prosthesis without any undercuts. So again, Ferrari et al. Has actually come up with another modifications with this along with MDPT techniques. So in 2017, he came up with another type of restoration or preparation techniques known as posterior indirect adhesive restorations, or PIAR. Here, he divided the restorations into proximal preparation design, bevel preparation, butt joint preparation, and shoulder preparation. Here again, the proximal preparation design, these three are new rather than the MDPT technique. These three are actually very good, very helpful for us when determining the tooth restoration or tooth preparation at the proximal side. First one is the slot, bevel, and ridge up preparation. So we'll just see what are all the indications and for these preparations when you are going for it. So butt joint, as we all know, the butt joint, we are usually going for a tabletops and endocrons, or when there is a cuspal reduction to protect it from the occlusal load. And when there is a cuspal fracture at the occlusal third, we can go with this kind of preparation. But so this is the one I said, but is just following the fossa and occlusal reduction, but there is an inclination towards the occlusal side. It's just not a horizontal cut or a horizontal reduction. We are just following the inclines of the occlusal surfaces. And there will be always an inclination towards the occlusal side. And clinically, this is a picture, it's an endocrine picture. You can see the shoulder, butt joint preparation throughout the preparation. So this is the clinical picture, clinically how it will look. On top of this, we just lute our processes with proper adhesive strategies. Next one, bevel preparation, again, is mainly of aesthetic need. Usually when there is a wide surface of external enamel which enhances the adhesive cementation procedure. Here again, this one we will utilize especially in the buccal surfaces of the tooth, like you feel that an extra retention is required without preparing the teeth. In that case, we can just give a bevel or 45-degree bevel to 1.5 to 2 mm of bevel at the buccal surface. Usually we will give bevel at the buccal surface. Lingually, we won't give that bevel. Usually lingually, we end up in butt preparation. So these are all the other bevel preparation. Again, the picture, when I show you the clinical picture, it will be quite easy for you to understand. See this preparation, mandibular premolars. Actually, the retention may be compromised if you just give a butt here. So what we have done, we have just give a small bevel preparation at the buccal as well as at the lingual surface for the better resistance and retention for the prosthesis. So it is mainly of aesthetic as well as the retention purpose. In case you feel that or you doubt our retention may be compromised in case of especially premolars. So shoulder preparation, as we all know, if there is a cuspal fracture up to the cervical third or great structural protection is required for a good cusp coverage with the cervical grasp. In that case, you can go for a shoulder preparation. This is the ideal picture for that. See, this is a cervical, the cusp fracture till the cervical lane. So we have to, there is no other enamel to preserve. Only at the cervical third, the enamel is present to preserve it. So you can use the shoulder preparation to preserve that, however, enamel or that much enamel at the cervical third and go for the prosthesis. So next thing is our proximal preparation designs. Actually, this is very important. This by Ferrari et al. This preparation is actually useful when you are going for the maximum of invasive, minimal invasive procedure. First preparation. So we have the enamel is only at the cervical third and enamel is present to preserve it. So you can use the shoulder preparation to preserve that, however, enamel or that much enamel at the cervical third and so next thing is our proximal preparation. So we'll start with the slot preparation. Usually slot is the one which we are always doing with. But with the slot, like the slot is after all carious excavation. Usually we will get this shape here. So that is the slot preparation. We are this is a common preparation which we are using for our daily basis. So here nothing we are giving using a shoulder finishing bar, but to get a rounded shoulder, we can see a rounded margins or rounded line angles for the slot preparation. And next one is the bevel in the proximal. This is actually we will do when you are in a dilemma whether I have to cut through this marginal ridge and reducing the integrity and the strength of the tooth. So in that case, actually you are just going with the bevel in the proximal preparation. Nothing. You just go with your butt joint and give a more bevel at the proximal area, minimum of 1 mm. At the proximal area. So here we are not cutting the marginal ridges. We are just preserving the marginal ridge and we are just extending that preparation as a bevel to the interproximal side for the maximum of adhesion. And these two actually ridge up and ridge coverage in the proximal is a very good preparation for preserving the integrity of the tooth. See this ridge up again. We might have come across this kind of dilemma again when a class 2 or just a cusp coverage or for an overlay. But doubtful is whether to incorporate this part of the enamel marginal ridge or not, just like that, leave just like that. This question will come up always when we go for a ceramic onlay, not an overlay. Some few cusps we are going for, aim to cap. So here actually in this picture, the clinical picture will be easily understandable. See this here all buccal, butt and incline, and here I have actually preserved the marginal ridge, like with the ridge up preparation. See, I have not incorporated that part of the enamel ridge, marginal ridge into the preparation. I preserved the marginal ridge well. So before going for this kind of preparation, you have to keep something in your mind like the quality of the marginal ridge present. If there is any kind of cracks or any kind of the smooth caries or decay present in the marginal ridge, better to incorporate that marginal ridge with a bevel in the proximal and incorporate the marginal ridge to your preparation. rather than your ridge up or ridge coverage in the proximal preparation. So these are all actually this proximal preparation design is very useful when you are preparing a biomimetic restorations. So now a question would have come in your mind, why always we are talking about normal teeth, like normal axis, normal class 1, class 2, or 1 or 2 cusps are involved. But endodontically treated teeth means not only always like one very strong teeth. It will have, sometimes there will be compromised teeth, there will be mutilated teeth. So what will you do? We will just go with our normal post and crown. We'll just forget about the biometric principle. A normal all technique will be follow or not. So when I started my biomimetics, I used to think like that. What will I do when if mutilated teeth comes to my my clinic or my department? What will I do? So Clennell et al. In 2022 comes up with a new approach like no post, no crown approach. It's actually he just following the bio-based concept, like reconstructing the base of a tooth with the dentine, like using our polyethylene fibers and short fiber reinforced composite resin. When we see the polymerized polyethylene fibers, we may wonder what is this new one. It's nothing new. It's our ribbon kind of ribbon fibers we are using here. So this is a clinical case report done by Clennell et al. Recently in 2022. Here, this is a mutilated premolar, mandibular premolar. This is a clinical picture after obturation. So he decided to go with the micro etching of the dentine. Micro etching means the chair side air abrasion with your sandblaster with 60 micrometer of alumina. So we have clean up and we have whatever enamel is present, we have etched it to receive the maximum of mechanical adhesion. Then we proceed with the self-etch adhesive resin coat, and we used this ribbon fiber. He had used the ribbon fiber here. He took the ribbon fiber, wet it with the flowable composites, placed it from the palatal side, from the chamber, from the palatal to the buccal side. See, this is the placement. The glistening thing is actually. And next one, we have just used on top of the ribbon fiber, we have used the short fiber reinforced composite or SFR composite on top. Then the SFR composite is covered with our universal composite resin. So this is the, again, after the provisional removal, again, etched the surface, treated the tooth for the removal of the restoration. They have planned 3x4 disilicate crown for the same. So this is the picture, clinical picture with the prosthesis on, and a second A-B picture is the follow-up of 1 year. So the main limitation of this case report is that this long survival or the longevity or the term of experiment is only 1 year. So we need long-term studies to prove the longevity of these kind of techniques. Even we have done one procedure here for anteriors where the cascos were indicated. We did with the ribbon fibers and the composite restoration has been given, but I have only 6 weeks follow-up, so I didn't keep that picture into the presentation because I myself have to see how long it will survive. So going on to I'm talking too much about the adhesion strategies, biomimetics, good. So what does evidence says? We should see for the evidence-based practice, whether it is viable or not. So this is an article or a journal published in 2022 regarding the amount of tooth structure removal in partial and full crown preparation designs. And they came to a conclusion that a full coverage restoration preparation always remove 70 to 75% of the tooth structure. That is a huge amount. And for overlay and onlay restorations, we are just removing 32 to 47%. That means we can, the integrity of the tooth is still on. So resistance will be more. The next one regarding the preparation finish lines, I said you can to go with the hollow chamfer or a butt joint like that. So that rather than our conventional occlusal box reduction. So this Hassan et al. In 2023 is a very recent article. They just check the marginal leakage using these 3 different finish lines, and they came to a conclusion that hollow chamfer design and the butt joint designs are more suitable clinically than our conventional occlusal box reduction for an overlay restoration of the posterior teeth. So it's appealing actually. These results are appealing in terms of your finish line preparation. So next one, again, now the trend is systematic review and meta-analysis. So again, recently into 2020, systematic review and meta-analysis have come out, and they have told that they have concluded that onlays are a good, conservative and predictable option for restoring the dental effects with a survival rate of 90%. But again, another systematic review, they have come up with medium-term and long-term studies, like in 2 to 5, the survival rate is around 91 to 100%, but in long-term studies, it's more than 5 years, the survival rate is a bit less. But in this article, you have to see the year of the article, year of acceptance and publication. It is actually 2018, and we know all the new technologies have come up in 2017 from Venezia and et al. And Ferraris et al. So after that, this long-term survival study is not yet done. So there is a scope. You can do a long-term survival study on the longevity of the ceramic restoration following the principles of MDPT and PIAR. So next one now should come with the material of choice. Now the preparation is over. Now it's time to select which material is go with it. And when we see, usually we'll go with feldspathic or lithium disilicate, and zirconia is not a choice of biomimetic restoration. Why? Because it has got very low translucency and high opacity. So the aesthetic part will not be matching with our enamel. So always go with feldspathic or lithium disilicate. Generally, we will be using lithium disilicate for the preparation of indirect restorations. Then next one, now we have chosen it. They have chosen a nice material for that. Next thing is how to temporize it, whether the temporaries are required or not. Whenever a tooth is being cut, it's very, very important to professionalize or temporize the tooth. Still, we give our permanent restoration. So again, now whatever system we are using, like a system P, from Ivoclar, barricade, or stem bond, all things we can use for provisionalization material. Then you can use a non-eugenol luting cement to actually lute that temporary on the tooth. And one more thing I want to introduce here is the spot etching and flowable resin to lute the temporary. So spot etching and luting, when it will come, usually at what point you have to use the spot etching to cement the temporary. So usual cases. So if your cavity is like this, the cavity itself has some retention features like a box. So you don't need to worry about the retention. It will anyway, it will stay of maximum of 1 week. More than that, you can't expect your provisionals on. So within that time, go for that permanent restoration delivery. So when this is another scenario when this is an treated tooth and preparing for an overlay. So here there is nothing, actually there is nothing to retain, nothing, no two stops. There's a simple and a butt joint preparation here. So nothing to hold the temporary in place. So in that case, you can try with another kind of small preparation called occlusal lobes. It's nothing, it's a small round preparation on the dentine at the occlusal table, not at the enamel margins or the marginal ridges. It's at the occlusal table, a small. You can use BR3 bulb to create this. And this is the spot etching here. Again, with our phosphoric acid, we will etch that on the buccal and the lingual side of the tooth, not again at the marginal ridges. Spot etching and go for your self-adhesive resins and go for the temporary on the tooth. So the courtesy to Jeffrey Pong, recently published in 2021 regarding this technique to cementation. So now we have done all the protocols, selection, temporization also have done. So I just take you to a small revision of the clinical procedures, what all things have to be done in steps when you go for a biomimetic restoration or a biomimetic tooth preparation. So start with we have removed all our caries or old restorative material. And this first part you have to see your margins like distal or the mesial margin and check whether coronal marginal elevation or a deep marginal elevation is required. If so, go for it. So Rockatal has nicely described the different procedures for the bonded inlays and onlays. And next thing after the CMR, you have to go with your IDS and resin coating. As ma'am suggested, as ma'am told already, the IDS is actually improvising the bond strength up to 50% or 50% to the almost equal to the enamel. So Kim et al. Have nicely given the reasons, the importance of IDS, land DDS or delayed dentin sealing. Next thing is another procedure called cavity design optimization. Now everything is over, IDS done. Now you have to just check whether the cavity design optimization means whether is there any undercuts, or in the older techniques, what we will do if there is an undercut here. We will just prepare this part of the crown and we will incorporate this part of the crown into our preparation. So again, there's a mixture of enamel is gone. The integrity is again, we are cutting away the strongest part in our body. So this is CDO means nothing. Blocking of your undercuts, not incorporating that part into the preparation. You just block the undercuts, make it a more favorable thing to increase the strength. So again, this picture, even after the CDO, feel that the marginal ridge quality is not as good. Here there is some kind of crack here. So what we have done is we have just incorporated that marginal ridge into our preparation and make a MOD for the same. So next, going with the cementation protocol. So now our cavities on, everything is done, like all steps are ready, IDS, DME, CDO, all steps we have done. Next, go for the cementation protocol. The cementation protocol start with removal of the temporary, start with the micro etching procedure. Micro etching, I told already the use of 60 micrometer alumina, sandblast the tooth properly. Then cleaning of your tooth with either with the ethanol based material or propylene glycol, you can use for that. Next one, etching of your intangular surfaces of the prosthesis as well as of your teeth for the mechanical bonding or mechanical addition, improving the mechanical addition. Next one, you can use the silicization of the tooth as well as the prosthesis, again for the chemical addition improvement. And the resin cement application for luting. And this is the tooth on. So this is the courtesy to Alicia et al., which came to the case reports in the recent years, 2021. So one, I want to tell you the one trick or tip that before when you are going for the silicization, don't cure the prosthesis as well as the tooth, the bonding application. Don't process the teeth and the thing. Once we are light cured it, then I have a really tough time because the prosthesis was not fitting in, and it took around 2 hours for me to remove it fully. So next one, again, one more thing you have to look into. What about the failure rate about this? Because very minimal preparation, even though we are preserving the nature, what about the failure rate? Will it fail? Yeah, failure is also there. I can't tell that 100% success rate, but 100% success rate is possible if you are giving proper tooth preparation, properly adhering to the principles of the tooth preparation. Never, it won't come out. So it can be a bulk fracture or it can be a marginal breakdown. Usually it occurs at the cuspal coverage. And main thing problem is if the lithium disilicate needs minimum of 2 mm thickness. So if the preparation is less than 2 mm, chances are there it may fracture like this. So here you can see the fracture here. But if it fractures also, see the tooth structure. Our tooth is intact. Tooth doesn't get any problem. You may have to go for refinement of that tooth preparation. You have to go for the next one more ceramic impression and one more ceramic restoration. Yeah, of course, the economical, the cost of the treatment again matters a lot, but we are preserving the integrity of the tooth a lot. But in case of a crown, what will happen? Our crown will be always intact. When we are giving a crown to the tooth, we'll be telling crown will be intact, but we are not giving any guarantee for the tooth underneath it. So this is picture nicely described. So here, see, the crown is on. When it's a biorem is fully shattered, we are just giving the margin at the cervical region. So only the dentine is present, more flexion on the dentine. It's automatically, it just transfers the forces to the root. It ends up in root fracture, finally extraction and implant. So better always go with the biomimetically accepting restorations or acceptable restoration to preserve the integrity. So then the question comes in your mind, the cost is a problem, patient will make a problem if it breaks very soon. So you can try, what about the repair? Here in this case report, Manhattan et al. Repaired the ceramic overlay with Compoma. But again, it's just a 1-year follow-up study. So we are not sure whether we can repair it or not. So here actually we have started doing this procedures from 2016 till now. No patients have come back with the fractured restoration. So we'll wait and see what will happen. If so, what is we go for a Compoma repair or not? So these are a few cases which we have done in our department with the ceramic inlay and overlay. Onlay, here the picture, an onlay cutting. There are RC treated teeth, and we have just prepare only the portion whichever is missing, and you can see outline the bud at the buccal surface, a chamfer preparation at the buccal surface without much reduction in the tooth structure. Again, in the inlay preparation, an RC treated tooth. IDS is been performed in this. The same impression for the same on the cast fit-in trial and the cementation of the same. And the next one is the endocrown is actually a very useful restoration in case of short crowns with the minimum height for the tooth. So this is an RC treated tooth. The main criteria you should look into for an endocrown is the depth of your pulp chamber. Because the full retention we are going to attain from the pulp chamber depth. So if it is 6 mm or almost 6 mm of pulp chamber depth, we need to get a retention from the endocrown. So here, second picture, we have just give a flowable composite at the chamber area, and we have prepared the thing. And this is a interocclusal preparation design. This is an endocrown on. This is the picture with the endocrown placed in the patient's mouth. Second endocrown, we have in the second case, we have tried a bit different than the normal endocrown design. Actually, here there are 2 schools of thought. Nowadays, recently, all of us are doing this, the one which I showed before. In this preparation, we have just give a butt joint throughout. There is no chamfer here. Throughout the butt joint preparation we have done. And we have given some projections into the pulp chamber. So there are 2 schools of thought, like if you are giving a projection into the pulp chamber, chances are there it is creating more stress on the root canals and chances of fracture of the root is more. So this is the impression. You can see the projections into the root canals. And this is the prosthesis, how it looks like. So this is the clinical picture in the patient's mouth. And this is an IOP after the placement of the endocrown. with the extension into the chamber. So here, this is actually a 5 years follow-up case. Still the patient is doing well, no fracture, no pain, still on. This is another case. The complaint of the patient was actually repeatedly falling off composite restoration. Actually, it was a cusp capping done elsewhere with the composite. So we have advised the patient for the biomimetic restoration. The patient was ready for it. So we have just created here, since it's a fracture at the cervical third, till the cervical third. So I want to strengthen the tooth as a whole. So we just go for a shoulder preparation here and 6 to 10 degree divergence and extension into the lingual side. So this is the picture on. This is also just a 2-year follow-up. So with this, you might have thought only endodontic treated teeth can go with the biomimetic restoration, but ma'am, I've told nicely, even for the non-endodontic teeth can receive a biomimetic restoration with composite under proper isolation. You can give a good composite restoration following the principles of layering, incrementing, light curing, proper light cure under proper isolation. You can get a good bioaesthetic kind of restoration for non-endodontic treated teeth also. So last but not the least, all these procedures are possible if you are doing with proper isolation and with the use of any kind of dental operating or magnification aid, either in the form of loops or dental operating microscope. When you use the dental operating microscope or loops, you can clearly see the occlusal anatomy. So accordingly, you just have to run your bar. You don't have to worry a lot where to place what finish line I have to give. You just run the anatomy and go for the preparation. So to conclude, before conclusion, I just want to show you one picture here. This is a case came to our department, complaints of sensitivity. Here, the initial slides I have shown Brazos et al. That bioemulative model, by how the tooth looks like. Here, see the crown here. See the tooth here. It's almost like the same as of that article. See here, only that enamel rim you can see throughout. How nice the enamel at the biorim area. So I don't have to prepare anything here. I just run the ultrasonic tip of prosthetic ultrasonic tip and place my overlay on top. Just even the occlusal butt is almost done. It's just following the curvatures of the cusps also. So this is the nature. So it's not too much dealing. The biorim is still on there. You just have to go for the overlay without any preparation here. So I just want to conclude, like, maintaining tooth structure with biomimetic approach provides an opportunity for the patients keep their teeth for lifelong or a lifetime. So thank you for the patient listening. Thank you for KSR team giving an invite to present this in this platform. Thank you.
Thank you, Dr. Ramya, for that very informative talk.
Thank you.
Now, Dr. Sudarshana will ask questions.
Hi, ma'am.
Yeah, hi.
There are a few questions from the participants, ma'am.
Okay.
I will read one by one, ma'am.
Okay.
For endo-treated teeth, whether there is any specific indication where we can choose biomimetic restorations over conservative or conventional post and core with crown.
Once again, post and core, yeah. So you have to see the volume of loss. That is the first one. And you have to see the integrity of your marginal ridges. And you have to see whether quality of enamel is present. If there is quality of enamel, volume of tooth loss is less, and you can go ahead with your biomimetic restoration. There is no need of post and core for all, because when you are giving a post and crown, we are violating the biorim concept. So the enamel quality at the middle third, it's very important before you go for a crown and the biomimetic restoration.
Yes, ma'am. Thank you. The next question is, usually PGs will have doubt on this, ma'am, on the names overlay, onlay, tabletop restoration, or all these are overlapping terms, or is there any difference, ma'am?
overlay is actually a kind of, that is all in overlay. We are usually capping all the cusps, isn't it? Only we are leaving one or two cusps. Then in tabletop, the tabletop is indicated mainly for an abraded or an eroded teeth. For an eroded or abraded teeth, what we'll do, we'll go for conserve, maybe RC followed by crown. So here RC we will do, and here there are no cutting for a class 1 or a class 2. We are just giving a butt on the occlusal surface, extending the butt to the incline or as an inclined plane to the buccal surface as well as the lingual surface. Here comes the tabletop. We are generally giving for a short eroded or abraded tooth, or in case where we need a increasing of rising of the vertical dimension. In that case only we are actually going for a tabletop. Generally for an endonormal RC treated tooth, tabletop is not indicated.
Yes. Ma'am, is there any brand or specific composite that can be preferred for biomimetic restorations?
Yeah, we are actually using our 3M. SDR is the actually advocated one, as ma'am said. But we need again, it's a clinic, it's a hospital or college practice. So we need again the warmer for the same. So we can go with our classic packable composites for the same.
Then during the formation of occlusal log for retention, what is the reason for spar etching and why we should preserve the marginal ridges, they have asked?
See, if you are preserving in a spot etching on the marginal ridges, we are again demineralizing that margin, isn't it? So we maybe in 1 week, we all know that after the remineralization, it will take few weeks for the enamel to come back to the normal level. So within the 1 week, we will always give our permanent restoration. So the remineralization, demineralization of the enamel, to avoid that only maybe we can use that kind of spot etching only at the buccal as well as at the lingual side, avoiding the marginal ridge sides.
Then how does the effect of polymerization shrinkage of the resin over the fiber inserts match with the maturation of the hybrid layer? How do we relate to it?
It was breaking. Sorry, it was breaking.
The question, ma'am. How does the effect of polymerization shrinkage of the resin over the fiber inserts match with the maturation of the hybrid layer?
The fiber, when we are going for a FRC post and a fiber insert, that is the main thing. See, fiber insert, when we are going for a fiber insert along with the ITS, actually we are, it is of more surface area to etch and other. So usually the polymerization shrinkage will be always less with the fiber insert rather than going for a fiber post inside. That is why we better go with the fiber insert. So flexural strength also will be a bit more for the like our fiber inserts.
Okay, ma'am. Then if biomimetically restore teeth in future, if it requires root canal treatment or retreatment, how do we go about it?
Use your ultrasonic tip, it will come out. Don't touch the tooth with your burr. Use your ultrasonic tip at the power of 9 or 10. Automatically it will come out.
Thank you so much, ma'am.
Thank you. Thank you very much.
Now, please take the time to fill the post-test questions and fill the feedback forms. This is the certificate of appreciation for Dr. Subha. Please accept it, Dr. Subha.
Thank you so much.
Then this is the certificate of appreciation for Dr. Ramya. Please accept it, Dr. Ramya.
Thank you, ma'am. Thank you very much.
The certificate of participation will be posted to your email IDs. And now I hand over the session to Dr. Bhupati, who will give the vote of thanks.
Good noon all. On behalf of Department of Conservative Dentistry and Endodontics, I am glad to be standing here to express the vote of thanks. I thank our chairman, Mr. Srinivasan, for his constant support. I am very much obliged to thank our principal, Dr. Sharath Ashokan, for giving us the opportunity to host the CDE program. I would express my heartfelt thanks to both the speakers, Dr. Shubha and Dr. Ramya, for accepting the invitation and sharing their knowledge in this platform. Thank you, both of you. Also, I thank Dr. Prasad for technical support. I would express my special thanks to the organizing team, the department head, faculty members, and students for working hard for the past few days to make this program a grand success. I hope you all had a great learning, expecting your participation in future program. Once again, thank you all. Participants kindly all fill the feedback form. So it is a must to get your participation certificate. It is shared in the group out of the box WhatsApp group. Kindly fill it and send. Thank you. Post test questions too. Easily paste. Okay. Dr. Rani. சுபா இருக்கீங்களா? ரெண்டு பேருமே இல்லையா? இல்ல நினைக்கிறேன்.
சார் இதுலயே தான் இருக்கு. கூப்பிடுங்க சார். சார் ஏதாவது சொன்னாரான்னு கேட்டு பாருங்க.